a year, all the way through kids that are self-injurious, nonverbal, a young man that I'm working with in Harrisburg, Pennsylvania, who wears splints about 22 hours of his day, so he does not hit himself to the point where he will make or have severe damage. And in this career, what I've done and been able to see and look through the research is come up with, in my opinion, what is the 7 best strategies that whenever I go into a classroom, whenever I go into a work setting, whenever I go into a clinic, into a house, I'm looking at the individuals that are working with this kid, regardless if it's a parent, if it's a professional, if it's a grandparent. Are they utilizing these 7 strategies? And this is way before I even get into looking at curriculum, looking at structure, because most of our individuals, at least where I work, understand the principles of structure. Sometimes they just don't understand how to apply it, but they understand how to do it. Or they've been to a training where they bring it back and they can utilize it. However, they're not understanding exactly how to integrate it. Because I think from my vantage point, especially now working a lot of times with the little ones, it's critical that we're able to allow them the opportunities early in life to have quality and quantity of good services, because we know, again, through the research, that the better the quantity and quality of services at the younger ages, the better prognosis there is long term. And I go back into the early 80s working with kids in private institutions in New Jersey, where we had individuals there that never got early intervention, pretty much didn't get services for a very long period of time, stayed home a lot because they couldn't access the public school sector because of the severity of a lot of their behaviors. And it always dawned, or it always bothered me for many, many years is, what if these individuals had the same options that we have now? Because we know more about autism today than we knew 5 years ago. But the problem is, in my opinion, is that we're not spreading that word in a real effective way. We're giving a lot of people a lot of information. However, we're not integrating skills. We come out with kids that have really good rote skills, but those rote skills really don't get them employment. Those rote skills really don't get them a job out in the community, and they have no access to inclusionary opportunities. So having said that, the first evidence-based strategy that I looked at, and this all came out of my book. I wrote a book about 5 years ago, and it was called Early Intervention in Autism, Real Life Questions, Real Life Answers. And what I did is I looked at all of the different programs that were out there that said they worked with a student on the spectrum. Regardless of the evidence base, I went through every program that said they've ever worked with a kid on the spectrum and what kinds of strategies they used. I made a list on one side of the page of all the programs that I looked at, and all you have to do is Google it. And then I went across the top with all the different strategies that they used. And then I put an X in the box to figure out what strategies everybody was using. And these 7 strategies were the 7 strategies that almost every, if not every one of those programs utilized. So what should that tell us? That it's probably going to do something good for a kid on the spectrum. And from my, again, perspective, at that point, I'm also a board-certified behavior analyst doctoral, and I have been trained in applied behavior analysis, and it just happens that all 7 of these strategies comes out of applied behavior analysis. So having said that, the first one is repetition. And repetition, to me, is the most important one, and it's the one we think of the least, and especially in the social realm. We don't afford our individuals opportunities enough to practice skills. We talk a lot about in-situation social skills teaching, but we don't set up opportunities time after time after time. And if anybody here is an athlete or a former athlete or have kids that are athletes, if you watch how we teach athletes, it's exactly the same way. We do things over and over and over again. And why do we do that? Well, we do that so that the skill becomes automatic. They don't think about it. It becomes natural. It's not something they have to be thinking about all the time, because what happens with a lot of our individuals, especially in social situations, is they start to get anxious. And when they start to get anxious, those behaviors creep back in. And if they're given multiple opportunities, you will see a lot of those start to fade away. And with the majority of the strategies that are out there for social skills teaching, they can be utilized in order to have the individual practice them time and time and time again. And that is going to build that infrastructure for them to utilize the skill in situations when it's really important, because they're not going to know the difference. And I think that's critical to the entire process, because as I talk about each one of these, they build on each other. Because the second one to me is shaping. And you'll also hear that in conjunction with the third one, which is chaining, and they're very different. And we want a quick fix. We want things to happen now. And then a lot of times we expect a lot from some of our individuals when we really need to take the behavior that we're looking for, and we need to take small increments of it, reinforce it, and then at that point start to build on it. But like I said, we all want it now. And for some of our individuals, they're not ready now. And again, the fact that they can just do a rote skill for me doesn't mean that they can integrate it, which means they're not going to use it. And I think for a lot of us at sea, especially the younger ones, they'll come in with some pretty good skill level at the kindergarten. For us, the younger school-age children and the preschool kids, the real young kids, 3 to 5, and they've got some amazing skills. But you ask them to do one-to-one correspondence, throw out a bunch of rocks and say, give me 3. The kid can count to 1,000,000, but can't give you 3, which is the higher level skill, and which is the skill we really need to be looking at in order for that kid to integrate that skill and to be functional. Because if it's not functional, it's not going to be effective. Chaining is a way of teaching real complex behaviors. Usually we do chaining when it comes to domestic skills, personal care skills, and it breaks down that skill into its component parts, and it teaches each one up to the whole. So we would start out with toothbrushing. It might be a 15-step process. And we would teach the individual, and there's 2 ways to do it. One is through whole task presentation, and I'm not talking about those kids, because whole task presentation means you taught it once, the kid got it, we're good. I'm not talking about those kids. I'm talking about those kids that don't get it. And that's where we need to teach each step, reinforce it, make sure that we hand over hand or prompt that child hand over hand to be successful with it so that we build a chain. Because a lot of our kids can become very compulsive about how they do routines. And if we do the routines successfully, we can change those to our advantage, where the kid's now going to perform the behavior that we're looking for, and they're going to get out of it what they're looking for, which is the chain. So I look at obsessive compulsive behaviors in kids on the spectrum as a positive, as something that I can use to work on, not as a negative. And a lot of people do look at it as a negative, and I don't, because I think we can take those chains and we can make them to our advantage, where the kid will then have significant skill level. The next one, which to me is the one assessment thing that you should be doing most of all, and it all comes down to motivation. What's the motivator? And I was so happy to hear that you said you had candy in your office, because that's going to lure those kids in there. And once they're there, then I can start to teach. And it all comes down to motivation. These kids are not motivated like a neurotypical child. And you've got to find that. And the kids that are tougher to work with are the ones that you don't know what that motivator is, or the motivator changes minute by minute, second by second, day by day. And that's where I feel most of our assessment needs to be done, is because if you find what I call that to die for, you can teach almost anything to these individuals, and you can shape behavior to a very positive way. The next one, which a lot of people don't talk about, even in the adult community, which I think is critical, is play skills. And especially for our boys, because I think for our boys, what we tend to do is we tend to put them in reciprocal social activities at very young ages, and developmentally, they're not just ready for it. Girls are, but the boys are not. And as everybody probably knows, men are very different than women, and we play very differently. Because if I took a bunch of 7-year-old neurotypical boys here and threw out a bunch of dinosaurs, they would all be playing with those dinosaurs, but they would all be playing a different game. They would gravitate to each other on occasion, but they're playing very different games. If you had 2 girls playing, never a third, but if you had 2 girls playing, they would reciprocally socially play. So for me, with a lot of my kids, what I do, especially at the early ages, is really concentrate on effective play skills on playing with the material. Because the material keeps them in the social engagement. The social engagement then keeps them in the repetition. The repetition brings the anxiety down, which then allows the child to explore, because the other boys are going to accept them. Because I can't tell you how many times at the younger ages I hear from the neurotypical kids, he don't play right. And it's because of the material. My kid is in the corner hoarding all the Thomas the Tank Engines, and the other kids can't have access to them. The next one is, I'm trying to remember like the order, so forgive me. The next one is rapport building and behavioral momentum. In a lot of cases, we clamp down on our kids, and this is our schedule, and this is the way we're going to do it, when what we need to do is really look at, especially on those mornings when the kid comes in to the program, and you can see on their little faces or their big faces what kind of day you're going to have. You can change that day. And it's you who changes it. Because you can start with something that the child really, really enjoys. And if you do that, you get the kid back on a very good roll. You're in control of that. And then you can start to infuse those other things into the day that might be a little bit more challenging. And then the last one, and especially for the little ones, is something called extinction. It's your best behavior management strategy for your little kids. Now, I'm not talking about severely challenged kids who might put themselves or others or material in danger. At that point, we need to have crisis plans, and we need to do very good functional behavior assessment and come up with communicative ways for that child to get that same need or want met while we're shaping the behaviors we're trying to encourage. But for some reason, we want to jump on those kids immediately when they start to have bad behavior. And by doing that, we inadvertently reinforce a lot of negative behavior. And if you think about it, a lot of our kids are socialized that way. And they're used to negative attention. They're daredevils, they climb, and it's constant. Come here, what are you doing? Knock it off. And we give them a lot of feedback. And then what happens is, what do they seek out? They seek out the same type of attention. And we need to shift that. Because I propose that what we need to do is, as long as, again, they're not putting themselves or others in danger, what we need to do is at that point, critically ignore it. Don't ignore the kid, because extinction's not planned ignoring. Planned ignoring would be, which is another great, strategy, but planned ignoring is when you turn your back on a kid because they have the behavior because you want to withdraw the attention. It's a great strategy, like I said, but however, for some of our kids, that's attention enough to maintain a behavior. What I'm talking about is you ignore the behavior, not the child. So you continue to teach, you continue to reinforce. And if you do that consistently over repetition, and I know I'm repeating myself, you're going to have the child understand it, they're going to get more comfortable with it, the anxiety is going to go down, and they're going to risk more. Because I would hope that for everybody in here, and especially the way I view it, is every kid I work with, bottom line is I'm looking to put them in a better position to learn. That's my bottom line. And if I can put them in a better position to learn, they're going to develop good skill level. And I'm going to end on this note because I don't know how much time I have left and I could blab on forever. But the biggest thing I see, and this is all over the United States, and I see it everywhere, is the lack of urgency at the younger ages at developing functional communication systems. I don't know. I go into places and I just look at people, and the first thing I ask is, because I normally get called in when the kid is on their way to a private facility because they can't maintain them in the public sector. And the first thing I'm asking is, what kind of communication system does this kid have? And I just get blank looks like they're waiting through osmosis that this kid is all of a sudden going to start talking. And if you look at the research, the latest that just came out of Kennedy Krieger, they're saying that about 80% of kids on the spectrum will develop language. However, for most of us who work with kids on a day-to-day basis, we know they might have language, but how effective do they communicate? And in the work of, the late Ted Carr, who was another BCBA, just a wonderful man who died tragically several years ago, he wrote the best book on functional communication training that's out there. And it really looks at multiple systems in order to help these individuals to understand. I appreciate your time, and I'm sorry about the slides, so thank you.
Thank you very much, Dr. James. Our next speaker is Shahad Al-Khalifa. She's a pediatric occupational therapist, having a master's degree in occupational therapy and pediatrics and diploma in sensory integration. And she's going to speak to us about psychometric properties of sensory processing measures, preschool and at home among children of Saudi Arabia. And you have 20 minutes.
Assalamu alaikum. Today I will talk about the psychometric properties of one of the sensory processing measurements that we assist using ISD in Saudi Arabia. First of all, we will start with a brief definitions about what is autism spectrum disorder. We know that ASD is a neurodevelopmental disorder characterized by impairments in social interaction and communication skills. According to the DSM-5, one of the features of people presented with ASD, they always present with atypical sensory activity under the criteria of respected repetitive patterns of behavior, interest, or activities. So, sensory processing disorders is difficulty in integrating and organizing the sensation, could lead children to experience challenges in learning, cognitive development, and behavior. 45% to 95% of children with ASD assist using standardized questions present with sensory processing difficulties. Not only ASD children, also 5 to 10% of typical children present also with sensory processing difficulties. According to Al-Hizan studies, which is the only piece of research in Saudi Arabia, 84.8% of their sample percent of children present with sensory processing disorder at the clinical level. Unfortunately, none of them receive any occupational therapy intervention. Al-Hizan studies also highlighted the lack of opportunities of sensory processing assessment for children with ASD, also the lack of training of occupation therapists working with ASD. So why we need assessment for sensory processing? Discriminating characteristic of sensory processing disorder among clinical disorder is crucial. From a clinical perspective, classifying a specific set of symptoms will facilitate to develop appropriate intervention strategies, and also from research perspective, identifying a cluster of symptoms will facilitate investigating into associated neurological, psychological features. Usual occupational therapy, pediatric occupational therapists, use different methods to assess sensory processing in ASD children. For example, standardized and non-standardized assessment, family interview, clinical observation. However, when deciding to use the occupational therapist, the tests must ensure that the methods of test developed and standardized and norm also developed. So our aim of study was to improve the child and the family quality of life and also to provide opportunities for intervention and improve children's social and communication skills. And also we find the urgent need to provide Arab professionals with valid assessment tools. So to find which assessment will be helpful, we did a literature review using different databases, and the studies together argue that the sensory processing varies across cultural backgrounds, emphasizing the need to consider culture when evaluating sensory processing children before intervention. Also, we find the infant toddler sensory profile, which was adapted to the Arabic language. However, it's only assessed until the age of 3 years. Also, we find the sensory, the shorts. Sorry. We find also the short sensory profile, but in the study was unclear if it was translated to Arabic, and also it's only assessed age from 3 to 10 years. In addition, not all of sensory processing we find currently available to assess praxis and sensory system with social participation, or too long to administer. Finally, we find the sensory processing measurement preschool, which include sensory system, praxis, and social participation, and also a design for children with age 2 to 5 years, and it also can differentiate between typical development children and children diagnosed with a clinical disorder, include ASD. The SPMP home take approximately 15 minutes to complete, and also can help to discriminating between sensory and behavior difficulties. For the psychometric qualities of the SPMP had only described in the manual, and also for psychometric study with Australian sample, including children with multiply diagnosis. So there is need to be investigated further, particularly in different culture contexts, such as Saudi Arabia, to provide insight into the applicability of these skills in different cultures. So for steps of our research process, we will start first in psychometric properties of the English form, and to compare the results or to help in the second stage, which is translation and adaptation of the home form into Arabic. Finally, the last stage, it will be the psychometric properties of the Arabic home with ASD children in Saudi Arabia. So our research questions was, what is the reliability of the SPM in English-speaking caregivers in Saudi population? And also, can the SPM home discriminate between typical development and ASD children in Saudi population? We use a cross-sectional design and convenience sampling. For our study, the inclusion criteria were, first, the caregiver of children aged between 2 to 5 years, because researchers emphasize that the early assessment of sensory processing in children is as vital as other development signs and symptoms, which, if left, could continue into adulthood, resulting long-term global social behavior and emotion difficulties. In addition, caregivers of children diagnosed with ASD in Autism Research Center in King Faisal Hospital, because in CFAR, ASD are diagnosed by multidisciplinary team using standard diagnostic tools which follow the best practice guideline to diagnose individual with ASD. In addition, caregivers of children enroll in CFAR and preschools for the same region for a convenience sample. Finally, caregivers of children, both male and female, because we want to be a representative sample of gender and ratio. For the procedure, the caregiver of children with ASD who provide informed consent participate at center. And for the typical development group, the package was distributed by the teacher, send it to their home, and who consists to take a part, send it back with their children, and teacher give it to the researcher. The final sample include 40 TD out of 50 and 16 ASD out of 30. For the analysis, we use the data entered use SPSS, and for the internal consistency, we was examined with compact alpha, and due to the small sample size, a man-Whitney was conducted. And for the criteria-related validity, which is also known as non-group validity, affected size were calculated. For the results, as we see, for the TD group had approximately numbers of male and female, we can see here. And for the ASD, included mostly male. And for the TD group has relatively balanced number of participation in age groups, while the 3 to 4 years age were overrepresentative in the ASD group, which means that the mean average of TD were older than the ASD group, and in most cases the mothers completed the questionnaire. And finally, for the caregiver education, where the TD group had a mix of bachelor and advanced degree, where the ASD group mainly bachelor degrees. For the psychometric properties for the internal consistency reliability, in the TD group, the IRS was acceptable for most of the subscales. The large difference between the ICR was on the TD group and the standardizations group on hearing subscales. Also, we can see that the total score had excellent ICR, which is to the same level reported in the ECHA, which is the manual. And for the ASD, we can see the large difference between the typical group and the ASD group was on the vision. And we found that one item can rate negatively, which is the item is become easily distracted by looking at things while walking. And in addition, social participation was acceptable in the ASD group, but the item of takes part in appropriate mealtimes interaction was negatively. This is also some of items where negative correlate only on the ASD group, not on the TD, in touch, hearing, vision, and balance and motion. In addition, results showed that ASD group was significantly different from the TD group in all subscales. And also the result confirmed that more males than female in ASD, which is reflected in Saudi Arabia and other countries. And we saw that there are large proportion of 3 to 5 years old in ASD, with very few 2 years old represented. This is consistent with the late diagnosis in autism in Saudi Arabia, as well it could be results of lack of specific test. We know that in Saudi Arabia, unfortunately, ASD diagnosis was shamed by families. and which can isolate children from going out very often. And so some item could be a relative. For example, if children with ASD are ignored by their parents, inappropriate meal interaction couldn't be assessed accurately. And we know that in Saudi Arabia, families tend to live in large groups, so item refers to perceived noise from large groups or crowded might be problematic. And also we know that we lived in very hot weather, especially in Najd area, so children are unlikely to experience outdoor playing, so items with playground equipment would be difficult to answer. In addition, we know that Saudi Arabia caregivers might tend to overprotect their children, and culture variation could limit ASD with opportunities to stimulate physically. Finally, Saudi culture are different in parenting and could lend to different interpretation of behavior assessed in the scale. Our limitation were small sample size. We only focus on Riyadh, and we focus on English-speaking participation, which could be controlled for some extent. For further study, we suggest to see correlation between this study in English, we mean the English version with Arabic, with minimum 300 participation, and also another study to use the school form parallel with the home form. In conclusion, the SPMP home could be used in Saudi population, particularly as there are no other assessment for 2 years olds. And for the steps of the research, we finished with the first and second step, and we are on the third step, which is this is the Arabic one. Thank you.
Our last speaker today is Rihab Al-Saidi. She's a PhD candidate from Queensland University of Technology in Brisbane, Australia. And she's a lecturer at Taiba University in Medina. And she's going to speak about the relationship between executive functions and motor skills of children with autism in the Gulf region. 20 minutes.
وين القاعدة؟ Ladies and gentlemen, Assalamu alaikum. My name is Rihab Al-Saidi. I am a specialist in autistic disorder. Before I start, I would like to thank you everyone for taking the time to come here and listen to my presentation. My study explored two permanent themes in autism field. The title of my study is about the relationship between executive dysfunctions and motor skills in children with autism in the Gulf region. Today, I have divided my presentation into 4 sections. First, I will start with the research background that drove the formation of this study, and I will identify the knowledge gap in this area. Second, I will describe the methodology of the study. After that, I will present the result, and I have a general discussion. The final section of this presentation provide conclusion and make some recommendation. Okay, now let me start with the first area of my presentation. Please allow me to give you some definition about this key concept, executive dysfunctions and motor abnormalities. I will start with the executive function. Executive function, which refer to higher order functions closely associated with the prefrontal cortex, which are necessary for regulating and controlling behavior. They are also an important basis for the process of knowledge acquisition. They including a number of abilities, such as planning, working memory, mental flexibility, response initiation, response inhibition, impulse control, and monitor of action. The next concept I would like to explain is motor abnormalities. Motor abnormalities refer to a wide range of dysfunction in the neuromuscular process underlying movement, such as balance and coordination. One of the main brain regions that supports motor function is cerebellum. Cerebellum motor dysfunctions in autism including some difficult, such as eye movement abnormalities and fine and gross motor difficulties, as well as motor learning difficulties. Executive dysfunctions and motor performance abnormalities are hallmark difficulties of people with autism spectrum disorder. These difficulties can adversely affect the everyday life functions and the quality of life for people with autism. However, it remains unclear how the observed difficulties in executive functions and motor function may be related to each other in those with autism spectrum disorder. In general, motor development and cognitive development have been studied separately. Recently, Kane interested in the association among executive functions and motor performance abnormalities in the typical developing population and in the population with developmental disorder has increased. In reviewing the previous work in non-autism population, there have been different views about the relationship between motor skills and cognitive skills in children. On the one hand, some studies support this relationship. On the other hand, other studies don't support this relationship. These studies have been considered cognitive processes are completely different from motor processes. In the autism field, to the best of my knowledge, there are only 2 studies that have investigation the relationship between executive functions and motor skills in individuals with autism. These studies have support the correlation between executive function and motor performance skill in children with autism. Both of these previous studies were limited. In a study by Hilton, used a small sample size. She only used 7 children. Other study only investigated one aspect of executive functions, namely planning. In addition, these studies were conducted in Western countries. These 2 core aspects of function are significantly understudied in the Middle East, specifically among members of the Gulf Cooperation Council countries. Hence, there is a significant need for more research in relation to executive dysfunctions and motor performance abnormalities among children with autism in the GCC countries, that including definition and implication for the taxonomy, assessment and diagnosis of autism, as well as approach to treatment. Therefore, the aim of this study was to examine motor performance, executive function, and the relation between these aspects in children with autism. Now, I would like to move to the second section of my presentation today, which is describe the method in relation to participants and measures. The participants of this study were 119 children with autism and their parents. Their age range from 6 to 12 years. The participants were reacted from 3 Gulf countries, namely Bahrain, Saudi Arabia, and the United Arab Emirates. The inclusion criteria were children who score 71 or above, which indicates that a diagnosis of autism is very likely. Second, children with an IQ score of 70 or above to ensure that any identified performance difference will reflect of autistic disorder and not the level of cognitive function. 3. Children who score 22 or above on the Michigan questionnaire. This is the cut-off point for high-function autism. 4. Children who made the diagnostic criteria of level 1 on the severity scale in DSM-5. The exclusion creation was the presence of comorbidities such as epilepsy, severe self-engineer, aggression, blindness, and deafness. This study used two types of measure, namely scoring questionnaire and assessment measure. Scoring questionnaire including Gilliam Autism Writing Scale, the 3rd edition, and Michigan Autism Questionnaire, and Clinician Rated Severity of Autism and Social Communication Disorder. Assessment measure include the 2nd edition of the Behavior Writing Inventory of Executive Function and the 2nd edition of the Test of Motor Skills, both 2. Now let's move on the result of this study. The result referred a number of significant negative association between executive function and motor performance variables indicate that when executive function score increase, motor performance score decrease. The result found that all brief subskills and overall score were strongly related to the overall score of the motor test. However, no significant association between the shift subskill of the brief 2 and any components of the motor test were found. In fact, there are several explanations of the exacting of the relationship between executive functions and motor skills. First of all, special similarities between the development of motor skills and executive function. Special similarities indicate that motor and cognitive process use the same brain structure. It was a traditional thought that motor and cognitive development were two separate constructs. The prefrontal cortex of the brain was thought to be essential to complex human cognitive functions, while the cerebellum was traditionally thought to be the critical site for motor skills. However, it is now suggested that these constructs are fundamentally intertwined. More recent evidence indicates that cerebellum is involved in both motor and cognitive function, and the prefrontal cortex plays an important role in cognitive function as well as motor performance through strong neural connection between these two brain areas. Dysfunction of this brain structure or the neural pathways may express itself in motor problems as well as in cognitive problems. A second explanation is the temporary similarities between the development of motor skills and executive function. Both motor and executive function follow similar developmental timetables with accelerated development progression between 5 and 10 years of age and protracted developmental into adolescence. Delayed or atypical patterns of motor development can co-occur with certain atypical delays or difficulty in cognitive development. A final factor is that both motor and cognitive function have several common underlying processes, such as sequencing and planning. The lack of a relationship between motor performance and shifting function may be due to the neural process underlying the shifting function, which requires the recruitment of additional prefrontal region and may be mediated by different cortical area. Now let me move on the last section, which is the conclusion and recommendation. The present results support the view that motor performance and executive function are interrelated, which is interesting given the underlying common mechanism between these areas. Such relationships are critical to understand the centrality of the neurobehavior dysfunction associated with autism and determining whether one variable affects the other. The present study provides some recommendations for people working with children with autism, as well as for educational policymakers. The first recommendation is that policymakers should be aware of the importance of physical education in a class for the overall development of the child. The second recommendation is that teachers should be aware that children with autism have difficulty in terms of their executive functions and motor skills. Therefore, they should take this individual difference into consider when designing learning strategies. The final recommendation is that motor and executive function create bidirectional effect, and it is suggested that this relationship be used to enhance interventions to improve these functions. That brings me to the end of my presentation today. I would like to thank you, King Salman Center for Disability Research, for organizing the 5th International Conference, and Taiba University in Saudi Arabia for partly funding this paper. I would like to thank you for your attention today.
Well, this comes to our conclusion of this session, which is the first session in this conference, apart from the keynote speakers. I'm very happy to have two young researchers who are Saudis who's presenting today in this international conference. So I congratulate them and thank you, and please go forward, and hopefully you'll see more of your work and presentations in the future. I would like to have maybe 3 questions or maybe 5 for each speaker if times allow. So if anyone has any question, please be specific and direct the question. And we'll have countdown.
Thank you. Just I have a question regarding, we are underestimating the urgency of intervention for a child with ASD. I am agree. But we know about the management for the ASD. It's multiple things. It's depend on the family intervention with the child, depend on the school, and also in the institution. My question about the family, as Ms. Shahid Al-Khalifa mentioned about, we feel shame to take the child in the society and playing with other children, because there is, we can divide the stigma to enacted and self-stigma. About in the North American cultures, did you face any stigma among parents with ASD child or no? That's the question. It's different between the cultures and religions. I understand that point, but that's my question. Thank you.
No, absolutely. And it also cultural in the States too, because depending on the culture, some of the families, like our Hispanic families, will tend to circle the wagons and keep their kids inside. And some of our African American families will go to their church, and the church will circle the wagons around them there. So yes, we do the same thing. But I've actually had the gentleman next to you a conversation last night about this, and it was really, to me, so telling when he talked about even diagnosis. That play skills are the one thing that everybody forgets about, because they just think these things will just develop, or something's going to happen. And for these kids, in order for them to really truly be accepted socially, they need to be able to play. And for the families I work with, the stigma goes away when I help them to understand that they need to educate other people. So I give them, and it's very simple, I give them a card from the Autism Society that says, my kid has autism, this is what it is, these are the characteristics, so that when something does go wrong on the playground, when something does go wrong in the supermarket, they hand people this card. And I've had parent after parent come up to me and say, if you didn't do that, I would have kept my kid at home. And that's the worst thing we can do, because as they get older, as we know, they get bigger, they get stronger, and you can't get them out. And I can't tell you how many families I'm working with right now that have adult children that it's extremely difficult to get them out of the house. Now, it's not impossible, but it's going to take a lot more resources to do that. So if it's done right at the early intervention level and we get those families empowered to educate other people, we see greater success.
Do you have percentage for the stigma among these parents?
I'm sorry?
Do you have any percentage about any study related? Do you know the percentage?
Not that I know of. I'm turning mine off somehow. How do we turn that on?
Is this one working? Yeah. Tomorrow I'm doing a workshop on technology, and one of the things I'm going to talk about is a study that we conducted following the introduction of an autistic child onto Sesame Street. Does Sesame Street project here in Saudi Arabia? Yes? Yeah, well, if so, you need to really engage with the character of Julia. She's made a huge difference in the States in terms of acceptance both by parents and by the communities around them. And of course, we have to educate everybody, and that's just a lovely, positive way of introducing autism to the community. And there's some wonderful online resources for her, too.
One final question if there is, otherwise we can... Okay, thank you very much. I would like to thank our speakers a lot for their contribution. I'd like you to thank you very much for being here and for the next session. Thank you very much. Thank you.